So let's switch gears, go back a little bit. Tiziana brought this up before, and this gets back to the biomarker thing. And so when I want the truth about something, I always ask Heather. So we're going to talk about tumor mutation burden.
Can you talk to my kids?
Tumor mutation burden. We had a little flash in the pan a year ago, I guess, at AACR, right? And there was a lot of optimism that's kind of been quelled. And I just wanted to get your thoughts and others' thoughts on.
I think they're ongoing flashes, right?
Yeah.
So, and I think that's where it's so confusing because, again, when we're talking about biomarkers, there's the really clear-cut, no question biomarkers like having an EGFR mutation or not, and then there are the somewhat fuzzy, like PD-L1, right? And then there's the really could be a lot of different things, which is tumor mutation burden. Because in order to establish a tumor mutation burden cutoff, it's going to be dependent on how many mutations are you looking for. And in most of the definitions, it's excluding all of the known drivers, so you're just looking at all the sort of other things that we don't yet understand. And different assays have different numbers of mutations they're looking at, and then they've established different cut points. And so whenever I see a biomarker where there's gradation and people pick their cut points, I get a little skeptical. And this is, I think, one of those settings. So there absolutely have been studies where they picked a good cut point and were able to show, hey, this mattered. And others where it hasn't. And so it's just hard to know what's the actual truth of it. That being said, I think there is some truth to it. In the way, when I'm trying to describe immune therapy to patients, I talk about the two aspects of it. You've got to have something about your tumor that's different than all of your normal tissue. And that is sort of tumor mutation burden, but it's not exactly tumor mutation burden. And then you have something you're doing that helps the immune system recognize it. So with the PD-1, PD-L1, you're turning off one of the stop signals. And if that's the stop signal that's important, then great, that's really critical. But if there are other stop signals, then that's irrelevant. And if you take away your stop signals, but there's nothing that helps the immune system recognize the tumor, then you're stuck also. So I think there's probably both sides that are relevant, but I don't think that the tumor mutation burden as it's defined today is the full truth.
And often, depending on where you may send your samples, for those people that are sending samples outside, you often may get that in your report. We won't name names, but Paul, your thoughts on because I get asked by community oncologists, what do you do with TMB? And I say I ignore it right now.
Again, I think there are two ways to look at this. One is from the perspective of TMB, as sort of like as much of a binary biomarker as you can get, where you have essentially very little tumor mutation burden or thousands, right? And so the colorectal cancer experience tells us that this is functionally important in terms of mismatch repair deficient colorectal cancers, Lynch syndrome, right? So in practice, using that theory, it does matter. The question becomes in the context of other malignancies like lung cancer, small cell, non-small cell, in the spectrum of tumor mutation burden that we see, is this functionally operant as a biomarker? And that I think the jury is still out on, right? I mean, there was that initial promise with 227 last year. It was not borne out on overall survival. Mystic was not borne out. Overall, in terms of tumor mutation burden for the tumors themselves, that wasn't bore out. There's this blood-based mutation burden at a different cut point that seems positive. Again, very difficult to make heads or tails of in terms of what exactly is going on. But I think for all the reasons that Heather had mentioned and the fact that it's just very difficult to get anything consistent, it makes it a much less reliable biomarker. And so I'm similar to you, when I do get it, which is also by and large much after I am treating the patient actually, right? There's that practical aspect. It's sort of, well, this is interesting. Maybe as like a 5th line or 6th line therapy, I'll give Ipi-Nivo or something like that, but, and so for me, that's the utility.
Corey?
I divide the world, the thoracic cognoscenti, into 3 groups. The TMB cultists, and they know who they are, a small minority. TMB agnostics, and I think I'd probably put myself in that group. I'm not sure what to believe. And I agree with Paul that the jury's out. And then the TMB skeptics, and skeptics can also be agnostics, and I'd probably say that the majority of us are in one of those two categories. But that being said, there, as you both pointed out, there's tantalizing data. There was a blood-based TMB analysis. Granted, it was post hoc. It was, as my favorite phrase, hypothesis generating, but in the 20% or so that had higher than 20 mutations per megabase in this blood-based assay in the MYSTIC trial, there was a survival advantage. Is that enough to carry forth a separate phase 3 trial comparing a CTLA-4 PD-1 inhibitor in combination versus chemo? Remember, the control was just chemo, and that's not what we're standardly using. We're using chemo plus a PD-1 inhibitor. The other group is actually one of the sub-analyses from Haas Borgai's presentation last year at ASCO, and that's what I call the immunotherapy desert. Low TMB, low PD-L1. And in that group, the combination was certainly no better and frankly inferior. There was an early dip in survival, but chemo did just as well as chemo plus nivo in that population. It was small numbers, but there is, without question, a population that we have not fully identified where checkpoint inhibitors, at least in their current status, are probably doing the patients absolutely no favors.
Right.
And that is a group where I would have equipoise. I don't think any company would do this, but maybe the cooperative groups would, of looking at chemo, perhaps chemo bev versus checkpoint inhibitor in combination with chemo, we'd probably do just as well.
And Mark, I think, as you had pointed out before, in Checkmate 227, we also saw in the ipi-nivo patients that early degradation of overall survival and PFS before the curves cross. And that is an area of concern still for that subset where clearly it's not working and they're just not doing as well.